Welcome, members. Thank you for coming. We have a special guest today. Christopher Pope has joined us. Christopher is a senior fellow at the Manhattan Institute. Previously was director of policy and research at West Health, a nonprofit medical research organization. He's a health policy fellow at the U.S. House Committee on Energy and Commerce and a research manager at the American Enterprise Institute. Chris's research includes the Affordable Care Act, Medicare, Medicaid, and healthcare delivery reform. Chris's work has appeared in places like the Wall Street Journal, Health Affairs, U.S. News and World Report. He holds degrees in government and economics from the London School of Economics, as well as a master's and PhD in political science from Washington University in St. Louis. Chris, thanks for joining us. Welcome to the Florida House.
Thanks for inviting me. It's great to be down here and escaping winter a little bit, although thankfully I live in New York, and even now it's still kind of straggling on there.
We were just talking about how jealous he is about our weather and our beaches.
Yeah.
So Chris, we have you down here today to talk about, really an article that you had written about the costs of hospital protectionism. And, I want to kind of create a little bit of a context for the members that are here today. You talk a lot about, kind of the historical framework about how we saw a rise in cost in healthcare and what some of the, what your research has kind of bore out is the cause of that. So can you give us kind of an overview of what you see as kind of the historical look? How did we get here?
Yeah, I think if you sort of look at the media and you sort of follow the public debate on healthcare, we talk a lot about insurance. We talk about insurance coverage, we talk about insurance competition, we talk about insurance premiums. I think there's a real sense in which insurance is like the visible part of healthcare. It's what you interact with as a consumer, and you kind of are very aware of insurance costs. And then hospitals are kind of like under the waterline a little bit. People are not necessarily as aware. I mean, they get their explanations of benefits. They're certainly, if you need major surgery, you're aware of very big numbers. But I think people don't really have a good sense of the politics and the policy is really driven by the costs that are accumulating on the delivery system side and in hospitals in particular. And I think from a political point of view, it's particularly important. People always think that the insurance industry kind of directs everything and then they procure services efficiently. But the system's really very much set up, I think, from a political point of view to put the hospitals in the driving seat. And the insurance industry is kind of left to pick up the damage and pick up the costs. And when we talk about insurance market competition, we're really kind of talking about redistributing costs that are pretty much set in stone by the nature of the hospital industry. I mean, there's not much ability in most of the country to shop around. Hospital costs are enormous and inequitable. And insurers, it's kind of like a desperate scramble to find the money and trying to get it from people afterwards. When what we're really talking about is reducing costs. And reducing costs means insurance is more affordable, but it also means that public funds can go further as well. And so the nature of the delivery system is really the elephant in the room. The hospital industry is really what we need to be working around. And then, to the extent that we can reduce costs on the hospital side, every other question becomes a lot easier when you start tackling that. The questions of insurance, affordability, the question of entitlement affordability. Those questions are really determined by the structure of our delivery system that underlies everything.
I have two small kids, and we read every night, and usually the stories are superheroes, and there's always a clear villain. And it seems like in your article, if there was a clear villain, based on some of the research you had done, the villain was government's involvement in the healthcare marketplace. So what are some kind of specific examples that you've seen where government has intervened in a particular policy that you've seen as a kind of a perverse consequence?
So the article that I wrote on the hospital industry was talking about it as hospital protectionism. And I think that's really the best way to understand the dynamic. Like in trade protectionism, the fundamental impulse, I think, is a good one. I think in politics, it's sort of useful to talk about organizations as villains. But, where does power come from? It's fundamentally that they're providing a useful service. Everyone really values their local hospital. It's a place to get care. It's an important employer locally. It's really a pillar of the community. Like, what makes your town a good town? Like having a hospital that's a good hospital, it makes it a thriving town, and it makes it a town that people want to live in. So that's a real important factor. But also there's kind of like a downside of that. Now, there are important services that really absolutely need to be done locally. Emergency services, trauma services, some cardiac services. Time really is of the essence there. Like whether you can get treated for these services in under an hour or under 30 minutes really greatly improves quality of care outcomes. But the important thing to remember is that that's really only a small share of what hospitals actually do and a small share of what healthcare is. Only 7% of hospital spending is actually associated with emergency care. So 93% of hospital spending is elective care, things that people could travel around for, things that people could go to neighboring towns, things for which people could go to specialty hospitals and more efficient providers. And so what I think has really happened in the healthcare industry and the hospital industry is that as policymakers, we got trapped on a bit of a bait and switch. Hospitals are really essential for emergency care services. And those really do need to be done locally, and they need to be done well locally, and they need to be assured locally. And hospitals really do need to be supported in providing essential uncompensated care services locally. It's a truly essential community service. But the vast majority of what hospitals do does not need to be done locally. And you really can have competition. You really do need to have competition for the vast array of elective care services. I think the best example of this is in California. There was the issue of how to pay for knee surgery. And they found that the state of California, its pension system ultimately was paying for knee surgery for many of former state employees, and so it was paying between $20,000 and $120,000 for identical knee surgeries across the state at different facilities. That's an enormous difference. Now, I mean, like, it's important to have emergency services done locally. It is not important to have knee surgery done in your town. And actually, I don't think people really care that much about whether they have their knee surgery done in their town. They want it done best. They want it done with the lowest risk of complications. They don't want to have it done again. They want to have it done in a cost-effective way. I think it's generally the case that if you are a physician, if you're a surgeon, and you are very specialized, you've seen many cases of the same sort in the past, then you're going to do a better job than surgeons who are kind of dealing with a couple of cases of a certain kind once or two times every year. They're not going to do such a good job. And people actually, for the vast majority of elective care surgeries, they want to go where it's done best and where it's done cheapest, and often those are the same things. And so when you have low volumes locally of what are essentially elective care surgeries, what happens is, because healthcare is so much about high fixed costs, well, if you have high fixed costs to cover in these services for a hospital, it's very hard to do efficiently. You have to essentially divide up those high fixed costs between the low volumes of services that you're delivering, which means you have to find a way to charge large amounts of money to all the patients that are coming in the door. And you don't want to do it. There are some people who really can't afford to pay a large amount for these services, and so you make the people that can pay more, and you try and pass on the costs to insurers and taxpayers. And that really is the driving factor behind so much of the cost growth. We're trying to do too much locally. There are some things that really do need to be done locally, but the vast amount of things that we're trying to do in terms of hospital care doesn't actually need to be done locally, and that's why we're being stuck with all these costs.
You talk about that in the article, of course, and one of the things you kind of look at is not just kind of how this looks nationally, but I think maybe to compare us internationally and how other countries, particularly in the UK, and really the amount of hospitals per capita. So I mean, if you look at the United States or places like here, like in Florida, how do we compare to the amount of hospitals per capita as they do maybe in some places like the UK?
So I grew up in England, as you might still be able to tell a little bit from my accent. And I think whenever we talk about comparing healthcare systems across countries, it's like the same old story. We talk about the insurance as if that's the most important thing. Oh, well, the United States has private insurance and Britain has publicly funded healthcare. And we assume that that's the biggest difference between the countries. I think the better perspective is really to look at the delivery system. What is different in the delivery system, and that rather than who pays for it, and that's a slightly separate and kind of secondary debate. If you look at the amount of hospitals in the United States, there are 4,800 hospitals in the United States. In England, there are 200. 200 versus 4,800. Now, obviously, England's a smaller country than the United States. It's not that much smaller. Even on a per capita basis, the United States has 4 times as many hospitals as England. And that's really what's driving the costs. You have to find a way to pay for this hospital care. Now, these hospital care, you can do it through, public sector, or you can do it through private sector. Even when you look at the public sector in the United States, as a share of the economy, the United States government, all areas of government, spends more than the British government on healthcare. Britain is supposed to be the country with socialized healthcare. The government alone, ignore all private insurance and all private out-of-pocket spending. The government alone in the United States spends more than the British government does as its share of the economy on healthcare. Why is this? It's ultimately because of the delivery system. It's ultimately because of Britain's very large, the United States' very large amount of hospitals, very large amount of capital that's invested in its hospital care. I think an example that I have in the piece is really, now obviously not everything in healthcare is an MRI scanner, but it's a nice discrete example of the type of costs that are typical in healthcare. So if you compare the United States with France, for example, the amount of MRI scans per 1,000 inhabitants, in the United States is 118, in France is about 105, not that different. The amount of MRI scanners per million, in the United States it's 39, in France it's 13. So we have about the same amount of scans, but only a third of the amount of scanners. The average price in the United States for an MRI scan is $1,121. In France, it's $363. So it's like you do the math. It's like you divide the amount of scanners by the amount of scans, and it actually works out remarkably similarly to the price difference. It's these delivery system questions that are really at the root of the cost challenge. The costs come from the delivery system and then filter up to the insurance world, and not the other way around to a large extent.
So you talk about capacity, and I think you're talking about that a little bit in the scanners, or you talk about bed capacity at hospitals. A lot about excess capacity at hospitals and inside the hospital market. We're taught in economics, even if we didn't go to the London School of Economics, right? That supply and demand, right? So it seems as though if there's an excess supply, we would expect costs to go down. You argue the reverse in your article. Why?
I think that's fundamentally because of politics. Because we have this political pressure to protect everything being done locally. Now, in a normal marketplace situation in any loosely regulated industry, if you have this enormous amount of overcapacity, competition would eliminate it over time. Hospitals that are able to facilities would lower their prices on MRI scans. The ones that are not able to lower their price for MRI scans would stop doing MRI scans or wouldn't even get into the business in the first place. And you would have the appropriate level of capacity, and each facility you would end up with many fewer facilities doing many more scans. They would find ways to greatly increase the amount of scans that they do. I don't know, they would find ways to schedule appointments and bring in people at cost-effective times. I mean, if we're talking about $1 million piece of equipment, you want to make good use of it, and that is your cost that you're then going to have to find a way to finance. And so it's by essentially impeding competition that we've been stuck with this enormous overcapacity and this very, very high cost base.
So most of the members here are involved in the conversation about, how do we lower costs, in healthcare for our constituents while maintaining or increasing, kind of quality care. And you talk a lot about, government involvement, particularly at the federal level, about legislation around critical access hospitals, the Stark Law, certificate of need, and legislation around ambulatory surgical centers. What have you seen as kind of the practical implications of those policies, and what does your research say about them?
So I think the certificate of need example is a good one, because I think a lot of the rhetoric of certificate of need is almost in the direction of what I'm saying. It's like, well, we want to be careful of overcapacity. But when you actually sort of look at what certificate of need laws are written as doing and what they actually do in practice, they provide very little constraint in terms of what hospitals can do. They do nothing to prevent hospitals from spending money and increasing their capacity. What they do is they prevent competitors from competitors to hospitals from increasing capacity and essentially entering into the market. So instead of doing what they're supposed to do, or what they claim that they're doing, which is eliminating overcapacity, they actually have the opposite effect, that they prevent competitors from eliminating inefficient providers. They prevent competitors from squeezing margins on things that really shouldn't be done and reducing prices. And so certificate of need has a very, very strong push in the wrong direction in that respect. I think when we think of hospitals, the politics and the economics are very intertwined. My background is as a political scientist, and I think often in healthcare we hear a lot from the economists. But there's a real political dynamic here, which I think can be characterized as the too big to fail dynamic. We talk about the too big to fail financial institutions, but really in the hospital industry we have a too big to fail dynamic as well. We have the hospitals that are doing every single service, orthopedic surgery, oncology, cardiology, the whole gamut. And they say, if we're not making a profit overall, we're going to have to shut our doors for everything. Again, there's the bait and switch. It's like, we're going to shut down the essential emergency care surgery if you're not letting us make sufficient profits on elective care, which is the bulk of things that don't necessarily need to be done locally. And so I think if you allow specialty hospitals each to do each focus on a specific service line, they can get much better at it, do it much more efficiently, get that knee surgery done well, do it better than anybody else because they're only doing that, and find a way to do it in a cost-effective way, and be accountable in competitive terms for having the best knee surgery at the best price. Regardless of what is the best facility for cancer treatment, you want to have your knee surgery done at a facility that is fantastic at doing knee surgery at a good price. You don't want to do knee surgery at the place just because it's a hospital that's good at cancer care. Those are two very separate skill sets. Those are two very separate organizational needs. And so once you start bringing these different hospital functions and separating them out as they ought to be separated out, you can actually start assessing each type of surgery and each type of treatment on its own individual merits in terms of value, in terms of quality, in terms of cost.
So you touched on this a little bit, but we hear these conversations. Everyone here obviously is concerned about the kind of care and the access to care that people in their communities get, particularly the uninsured, and are they going to have this access? And one of the things that we hear when we talk about these system reforms that you discuss, whether it's CON or others, is look, if we make this reform, we're going to be unable to serve the population that we're all concerned about. So I know you've done a lot of research around that. In places who've either maintained the status quo or done reform, have you seen a correlation between these reforms and access to care for people who are uninsured?
Yeah, so I mean, there are some pretty good econometric studies out on this. And what they pretty much across the board find is if you increase the profitability of, say, orthopedic surgery at general hospitals. Hospitals don't use the profits and redistribute them in any great extent to support their essential emergency care lines. They use the profits to get more orthopedic surgery because that's what's giving them more revenue. And so it becomes a self-perpetuating inefficiency. And because they're not accountable in terms of competition in any great extent, they're in no way pushed away from the inefficient service line. Now, from a public payer point of view, I added up all the various indirect hospital subsidies that are provided for the sake of supporting uncompensated care, supporting the provision of care to people who are uninsured or people who leave hospitals with bad debt. And if you add up all the different federal programs, and I just did this for federal programs. I don't know if Florida has additional state programs on top of this. If you add up what we provide for uncompensated care in terms of federal subsidies, we spend $80 billion a year justified purely in terms of hospital subsidies to support uncompensated care. The American Hospital Association itself says that the total amount of hospitals spending on uncompensated care is $43 billion a year. So even the hospital lobbyists, their claim of the amount of uncompensated care that hospitals are provided is less than the subsidies that we're providing for uncompensated care. And why is this? Well, the subsidies are provided indirectly, and so the subsidies reward the provision of inefficient orthopedic care. There's an elective procedure to people who are already well insured. And the subsidies aren't incentivizing the provision of essential and rewarding the provision of essential uncompensated emergency care. We need to get much better at focusing the provision of subsidies so the subsidies go directly at what we want to subsidize. And if we provide subsidies directly for emergency care and for facilities that are providing charity care to the uninsured and so on, we'll get better value for our public subsidies as well. You get what you pay for, I think, is pretty much a basic point in healthcare.
So I want to go back just to CON for a moment, because I think that one of the things when we talk about anything important, whether that's education or healthcare, is, hey, are we going to have some unintended consequence that has significant damage to our constituents and to our state? CON has been a conversation that they've been having here in the legislature for well before I got here, over 10 years. Obviously, it goes back to the 70s, and there's a number of states who've obviously repealed CON, no longer have CON laws. What can we, looking at those other states, are there unintended consequences? Have you seen positive effects or negative effects to those kinds of system reforms?
Yeah, so I think the certificate of need example is a great case because it's like it's in some ways the most purely protectionist measure. There are lots of policies like the way tax exemptions are structured for hospitals that are really protectionist in effect, but it's not clear what they're doing. With the certificate of need, like in many states, I mean the way these laws are designed varies a little bit. But pretty much universally, it functions to protect incumbent hospitals against specialty hospitals. Even in states where the certificate of need law is not written in a way that says this only applies to specialty hospitals, in practice, the certificate of need board is dominated by large general hospitals, and so they approve anything that's requested by a general hospital and reject anything that's proposed by a specialty hospital. I think a statistic on certificate of need that's very, very striking is that only 4% of the specialty hospitals that opened since 1990 are in the 37 states that have certificate of need laws. That means that 94% of the specialty hospitals are in the 13 states that have opened are in the 13 states that don't have these laws. Like, these laws are having a very, very big impact on the ability of specialty hospitals to enter into the market. And I think that is a very, very clear impact. Again, I think the MRI scan example is a pretty good one. Not because every cost in healthcare is an MRI scanner, but because it's very clear, it's very illustrative, and it's a very discrete example. And so MRI scanners are a very common target of certificate of need laws. And studies have been done on this, and they found that states with certificate of need laws don't actually have any fewer MRI scanners in the states at hospitals. What they do have is no MRI scanners outside of hospitals, which means that there is this elimination of competition. And so what you have is that if you sort of look service by service, where are the biggest markups in healthcare? It actually, like MRI scans, are actually one of the biggest because they're most frustrated by certificate of need laws. Like they'd be a very common target. And so you'll find that markups in hospital care services vary greatly from service to service, and some of the discipline of competition actually is greater. And the ability to have competition really does determine the extent of markups, and so they're really quite highly correlated.
You and I talked, backstage a little bit about the Stark Law, which is, candidly not something that I read a ton about before this. And you talk about it in your article, and it was really seems like it's a way to protect against kickbacks, but maybe just on one half of the market, not the other half. So tell us what the Stark Law is, why they did it, and what the impact is.
So the Stark Law is part of it refers to the Medicare program. It was an amendment by Pete Stark, I think, in the early '80s, and it's essentially part of a whole bunch of Medicare provisions which prevent self-referral. So in theory, it prevents a physician referring to a specialty hospital in which that physician has an ownership stake. So if you're an orthopedic surgeon and you refer to a specialty orthopedic facility, you're not allowed to do so for Medicare patients. But what's happened recently is that hospitals have begun acquiring physicians, essentially to a large extent for the sake of getting good referrals. And the Stark Law doesn't constrain that at all, because there is no ownership stake, and in fact, if the ownership stake goes the other way, or if the physician is a salaried employee of the hospital, any conflict of interest is as great as the conflict of interest that might exist with a specialty hospital, but the Medicare program does nothing to impede that, essentially, because again, the thought is the real intent of the law is to prevent competition by specialty facilities against large general hospitals, so that they can continue to provide all services locally.
One of the things we've discussed here, and is that people have made an argument that access to ambulatory surgical centers would create more opportunity for patients and maybe at a lower cost. The other side of it has said, hey, look, that's not safe when you're outside of a general hospital environment. It won't lower costs. What is your research around ambulatory surgical centers in states who've done it, and what have you seen as the impact?
Yeah, I think the quality. So there was a long literature on this, and I'm trying to bring it into mind. The quality benefit, I think, is, if I remember correctly, positive, if anything. Although with healthcare debates, there are always interminable arguments about, well, are the patients that go to this facility sicker, and how do you control for my patients are sicker than your patients, and it's really not truly a fair comparison. And so these arguments kind of get strung out, but I think it's certainly not the case that with ambulatory surgery centers you get worse quality of care. I think it generally, if anything, is the case that if you have physicians doing very discrete tasks many times over, procedures that are very, very similar, they get very good at them, and they get very optimized to dealing with the complexities that are involved in certain cases. And then, of course, there are liability provisions. I mean, no facility is going to open up if it's going to end up with a lot of patients with complications and with a lot of patients that then need to be transferred to another facility. That is not something that's in any hospital's interest to do as a specialty hospital. And so I think it's pretty clear that the market can work in that respect. From the early, the specialty hospitals were really an innovation, I think it's fair to say, of the 1980s. And this was really before they were, before regulations really impeded them to any great extent. And it was pretty clear that from the pattern of their development that you could really identify the areas that had the most specialty hospitals. There was a competitive constraint on pricing for the same surgeries, same services in general hospitals. Pricing was constrained, but also general hospitals that had to deal with specialty hospital competitors, their quality of care also improved. Because if you're facing competition, it's not just on the price dimension that you're facing competition, it's on the quality dimension as well. And so when we talk about local monopolies, if they're threatened by competition, the quality is going to go down. It's pretty consistent finding of the healthcare economics literature that when you have competition, not just does price go down, but quality goes up as well, because all of a sudden people start shopping around and you can't get away with bad quality services anymore.
You're no stranger to kind of giving advice to lawmakers about healthcare reform. You did it as a fellow in Washington. What's your, having looked at a kind of across the marketplace, for folks like us who are concerned about, making sure that we maintain quality, access to quality care, that we protect the uninsured, that our communities have good access to medical care. What's your advice to us in all of those things as far as policy reforms that we can do in a practical way to have a positive impact on both cost and quality?
Yeah, so I think I would kind of suggest that you always bear in mind the simple question, like, is this something that needs to be done locally in the hospital sense? Like, I think that really is the key question. And if you want it to be done locally, you want it to be done locally really well. And I think by making that distinction, you get to the crux of the matter. You don't want to do things locally badly. They're expensive to do locally. That are bad quality if they're done locally in low volumes. But at the same time, the things that are done locally, if you put all your attention and all your effort in to make sure that those emergency services are done well locally, you can focus the subsidies on that task and then make sure that the quality of local emergency care is better than it currently is. Currently, I think the fact that hospitals are trying to provide all services locally, it actually means that the ones that they should be done locally are not done so well. They're doing a bad job on the things that they are done locally, are supposed to be doing locally. And I think this is in some respect a big challenge for rural areas. Now, in some respects, this is a little bit beyond the ability of state policymakers to remedy, because it's again a bit of an offshoot of the Medicare program. A third of rural hospitals are paid under a payment arrangement called the Critical Access Hospital. A third of American hospitals, essentially rural hospitals, are classified critical access hospitals. They're reimbursed for inpatient services on very generous terms by the Medicare program. And the payment system is essentially, we're going to give you a very generous inpatient reimbursement, and you can use that money to cross-subsidize emergency care. And what has essentially resulted is that these facilities, which really shouldn't be doing large amounts of inpatient care in low volumes and bad quality, are still doing so in order to qualify for the federal subsidies, which they then use to subsidize their emergency departments. And so saying that the policy reformers are starting to look at in Washington is, why don't we just give them the money to support their emergency care? Why don't we just help them do a good job of that? They don't need to do keep people in the hospital for days on end, getting bad quality inpatient care. And so there are a number of states. I know that Pennsylvania has a demonstration that it's doing under the Medicare program to essentially flip the way it gets its subsidies. So it gets lump sum subsidies for emergency care so that its rural hospitals can become dedicated emergency focused facilities and let the low quality inpatient care go elsewhere. Florida could probably get a similar waiver from the federal government to provide a similar demonstration. And this means that you can actually maintain access to emergency care in rural areas in hospitals that are currently really struggling, genuinely struggling to stay solvent. I think that's a pretty good model if it's done right. And it's certainly a waiver that the state of Florida should actually consider. Should talk to CMS about this. And then this is a demonstration I think Pennsylvania's made good progress with. I think Maryland as well has kind of explored this. I know Florida, I looked it up, as a relatively urban state, so it might be less of a problem here than elsewhere, although I'm sure there are certainly areas in the state where rural hospitals are squeezed, and that kind of demonstration can be helpful.
Yeah, we always kind of say that Florida is like 3 or 4 states in one, as far as kind of our demographics and our makeup are concerned. Are there other things, I want to make sure we get this out before we just go to questions, are there other states that you look to and say, hey, they've been a real leader on, ambulatory surgical centers, and that's how this has played out? Or are there other examples that maybe we can look at as we have these policy discussions to learn from either what they did right or what they did badly?
Yeah. Well, the states that are doing things across the board right, I think I've struggled to sort of on the delivery system side identify star performers. I live in New York, and so it's very easy for me to identify a state that's doing things badly. A good piece of advice is look at New York and do the opposite. Generally,
we benefit from that greatly. Getting so many New Yorkers.
Well, I am glad I'm helping that research. But no, so I think there were definitely. I think it's generally helpful to look at policies discreetly, one by one, and say, like, on this specific initiative. Like, as I said, with the rural hospital model, Pennsylvania's model there is a pretty good one and worth looking at. I think there are this issue of surprise medical billing, out-of-network emergency care prices, so the issue that hospitals are driving up their out-of-network emergency care bit rates as a way to turn the screws on insurers. This is a problem that a number of states have been trying to fix. I think there are definitely some good approaches in that. A bad approach, again, is New York's approach. Don't do what New York did. But there are some states that are, I'm trying to think of the names. There are some states that have good proposals on that. Florida actually might have done some good work on that. And so I generally, again, I think it's good, actually. It's not a problem for the government to take ownership, have a larger government responsibility on emergency care, do a good job protecting that, and then get away from everything else, because it's only 7% of hospital care. Do a good job protecting those services, and it means you have more properly and appropriately free and competitive markets for elective care services, which is the bulk of care.
Well, let's open it up to questions. Any members who have questions? I think we've got, I don't know if we have microphones going around. Yeah, we have Representative Roach here in the middle.
Thank you. Thank you. That was fascinating. You started your presentation by talking about delivery systems, and you sort of compared a local higher cost procedure versus a high volume, lower cost facility that may be some distance away. I was wondering if you had any thoughts on sort of the rise of the HMO and how that plays into both streamlining costs, but also sometimes frustrating those delivery systems. If you could talk about that for a second.
So, I mean, I'm generally pretty supportive of managed care. I think ultimately, when we're talking about getting good prices for hospital care, we're really talking about the insurer as the main negotiator. It's not individuals that are really negotiating what hospital prices ought to be. And so the issue of making it possible for insurers to negotiate good prices over services is really the crux of the matter. These are experienced buyers. Like, I mean, if you just use knee surgery as a clear example, like most people who have knee surgery at most have had it done once before. Like most people aren't like experienced purchasers of this, but HMOs really are. And so their ability to essentially, I guess you could call it shop around, but negotiate with providers is important. Now, something that states have obviously done in recent decades has been selective contracting regulations and network adequacy regulations, which have tied the hands of insurers and HMOs in negotiating with providers. I think that is the wrong approach. I think obviously, again, the emergency elective care distinction is important. It's important to have insurers and HMOs required to cover broad networks and pretty much most facilities for emergency care. For elective care, for knee surgery, the government really shouldn't be telling an insurer what is the best place to get knee surgery and buy knee surgery from. That should be the insurer's responsibility. And if it's hands-on bound by the government in its ability to negotiate with providers, it can get a better deal. I think you're starting to see this in terms of centers of excellence for medical procedures and that kind of specialty hospital. The more freedom the insurance company has to essentially shop around and negotiate with the better providers, the better deal it's going to get, and the more savings it's going to be able to pass on to the people that are enrolled in it.
Thank you. Other questions? Yes, sir.
Thank you. It's been very fascinating. Just a question for you. You live in New York,
and we were just talking about surprise network billing. And I know in New York, it's relatively new what they had passed, which was sort of the arbitration, forced arbitration, where the insurance company and the provider take the patient out or the client out and allow them, if they don't like what they're getting paid, they can arbitrate with the insurance company through an arbitrator and they find that number there. Tell me what you see as it being wrong, or what you see as the observations from other people. I've heard that it's going well.
Yeah, so I have two problems with the New York approach. One is the fact that I think it is appropriate for out-of-network emergency services to have a regulatory cap on what you can charge. Like if a patient has had a heart attack, like you can say, you're not allowed to charge above X. And I think that's okay for two reasons. One, because the government's very heavily involved with emergency care in terms of it requires the hospital to provide the surgery. So it's like the service, it's not a free market. Like patient shows up kind of involuntarily at a hospital. He hasn't really chosen. Hospital doesn't have a choice but to treat the patient. And so there's no free market element to that for such an emergency service. And then again, because it's an out-of-network arrangement, it's essentially a default arrangement. If the hospital wishes to contract an in-network rate that's different to the out-of-network rate, that's not restricted by a regulation limited to the out-of-network service. So my sense is that you can regulate out-of-network, and it allows an insurer and a hospital to figure out a better payment arrangement if there is a better incentive scheme that they can mutually agree to. And then also it limits the abuse of market power, which is currently a big problem with respect to the out-of-network situation. What hospitals have been doing increasingly as a basic strategy is saying, we're going to charge what we know are exorbitant and unreasonable amounts on out-of-network care to force insurers to put us in-network for all care, including elective care. So they leverage this right that the law has given them on emergency services to basically charge people exorbitant amounts. And they've basically tied the whole of elective care to it and kind of used it to kind of create a dominant a market power and a pricing power that really isn't there. So the one problem I have with the New York approach is that instead of just capping out-of-network fees, they've put in a floor as well. Like there is something to be said, and I would say a good argument to be made for a cap really at an unreasonably high level. So I mean, you see some services that are charged 500% of Medicare rates for emergency bills. Like there's really no excuse for that. And so you can that's just a hospital trying to abuse its market position. A cap on that for the emergency situation in which there is no market constraint is appropriate. There is no reason for a floor being instituted at the same time, which is what the state of New York did. And then there's the issue of arbitration, which comes into that as well. And my view is that if policymakers are making, and legislators are making decisions, the job of a legislature is to weigh trade-offs. You can talk to stakeholders. You can hear from the hospitals. You can hear what's reasonable from their point of view. You can hear from the insurers. You can hear from patients. And you can weigh different concerns and considerations that they each have. What you're doing with arbitration is you're kind of saying, okay, we're going to kick the can or we're going to pass the buck to an arbitrator. And the question is this arbitrator going to have better information than the legislator is? And I think generally that's probably not going to be the case. If you're trying to weigh trade-offs, the legislature is the appropriate institution for weighing the trade-offs. And to the extent that there are trade-offs involved in out-of-network emergency care, I think it's better if the legislature takes that responsibility and decides what those prices are going to be, or decides the terms on which these prices are going to be determined. I think as a basic arrangement, saying some percentage of Medicare fees is quite reasonable. In the piece I've said 150%, and I think for a lot of hospital fees, that might be reasonable. One could say that 200% is a more reasonable cap for out-of-network emergency services and say that that's a better place. Or one could say that for an anesthesiologist, it should be 300%, whereas for the facility fee, it should be a different percentage. This is what legislatures are designed to do. You have that debate openly, rather than say, we'll let an arbitrator figure it out. Because then you might end up with a system that's not the one that you want. Like, better to take responsibility as a legislature for figuring out what the system is, rather than thinking, oh, this is a complicated problem, someone else will figure it out, and then you end up with a system that actually isn't the one, or that had trade-offs imposed on it that you didn't intend or you didn't figure out and you weren't aware of before they were imposed. So better to kind of have a proper consolidative process up front. And the other thing to bear in mind there is worth reiterating. Any price regulations, keep them limited to out-of-network emergency. And by taking ownership of the out-of-network emergency situation, you kind of say, doesn't apply to that 93% that isn't emergency. Let competition reign there. Let it be completely freely competitive. And then also limit it to out-of-network emergency. Because keep open the opportunity. If providers and if hospitals and insurers can figure out a better way to do it in-network, don't get in the way of that. Just have it as a backstop for the out-of-network. So for the in-network, don't get in their way. And also, the other thing with out-of-network is it helps folks that are paying out of pocket, people who are uninsured, because you really don't want to. That's when the really, really nasty scenarios come in of people who are like faced with $100,000 bills and there's no insurer to help them. So that helps those folks as well.
I think one of the big takeaways there seems to be New York continues to create teaching moments for us, which we're also grateful for. Other questions? Yes. Representative Pigman, Chairman Pigman.
I like your solution for the 7% that's emergency. Let me give you a slightly different scenario and see if the same remedy works. And this is I'm an emergency medicine physician, by the way, for full disclosure. But one of the consistent constituent complaints I get is the unexpected bill. And let's use a circumstance where it's a routine vaginal delivery, or even I'm going in to get my gallbladder taken out, and the patient has very dutifully chosen, in one case, an obstetrician who's in network, a hospital that's in network, and in the case of the gallbladder, this is surgeons in my network, this hospital's in my network, and then lo and behold, a couple weeks later, they discover the anesthesiologist was not.
Yeah.
So this is a circumstance that's not emergent. It's really very, to the extent that a delivery is scheduled, it's scheduled, yet that was a surprise billing. And I think pathology might fit in with that as well. What would you recommend in the scheduled procedure where those ancillary personnel are out of network?
That's a great example, and it's definitely an issue. I think the obvious from like an economic point of view, the efficient way to respond to that is to require that services be bundled, and require that any in-network hospital has in-network ancillary in-network coverage for ancillary services. So I think there's actually at the policy, at sort of like the research level, pretty broad consensus that that's the appropriate way to deal with that. Now, obviously, that's a bit of a political challenge, but that's your that's your job, not mine.
Thought I saw a hand in the back. Yes, Representative Grant.
Thank you. Thank you for your presentation. Can you talk a little bit about, you've mentioned delivery systems and how that all comes about. Can you talk about the impact of Medicare reimbursement on hospitals setting up those delivery systems? Because I think, if I'm correct, there's a disparity between what an ambulatory surgical center would get paid for a knee replacement versus at an inpatient hospital, but that's set by federal law. And talking about politics, it seems to me that we're a little frustrated as a legislature trying to modify those delivery systems when those delivery systems are really, driven by Medicare reimbursement, over which we have no control. So
this issue of it gets called a site-neutral payment reform in the Medicare context. Is the fact that Medicare has been trying to indirectly, for many of the same reasons, indirectly subsidize hospitals by reimbursing them more for for exactly the same procedures that are undertaken by ambulatory surgery centers, but also in independent clinics. So if you're an oncologist and you deliver chemotherapy, you get paid, I think it's like 2 or 3 times as much if you do it if you provide the service in a hospital than if you do it in your own clinic. Now, what's happened is that this has become a great incentive to consolidation. If you're an oncologist, I can get more money from Medicare just by like affiliating with a hospital, and so you see the very rapid growth in consolidation that is directly tied to these Medicare payment disparities. This is something I think on which it's a great example of how politics sometimes works. Sometimes the Obama administration budget had proposals to reform this and fix site-neutral payment. There's bipartisan agreement on this. Republicans agree that you could save money for the Medicare program as well by only paying at the rate of the more efficient site of service. Last week, the Trump administration issues this budget with this provision in it that was also in the Obama budget to reduce payments due to site-neutral payment and efficiency gain. Then you have this huge news story. Trump administration wants to cut Medicare by $800 million because it's advancing an efficiency gain. And so the administration gets hit for essentially recommending the same policy that the Obama administration did on a purely partisan basis. Now, obviously, the politics of this are really, really tough. Like the politics of, there's partisan politics that's opportunistic. There's provider politics. The hospitals care a lot about the reimbursement disparity. Not only does it mean that they get more money directly, but it sort of helps eliminate the competition because, I mean, like, they not only do they oppose their own rates being brought down, but they oppose the rates of the independent facilities being brought up. But there are ways in which you can kind of gradually politically move in this direction. You can kind of set up payment, kind of grandfathering arrangements, payment reform deals. With bipartisan agreements, you can sometimes slip things in there that are hard to undo. So I think once you sort of have, I'm sure you recognize this here as well, once you sort of have at the conceptual level an agreement that it's kind of unreasonable and irrational to be paying for the Medicare program and to be paying quite so inefficiently, you can find ways to get it into law through bipartisan agreements over time.
I think we got time for one more question. Any other questions? Yeah. Chair Burton.
Thank you, and I think you alluded to it in your last answer. Can you talk a little bit about this whole vertical integration movement that we're seeing in hospital care and the impact that has on cost to patients?
Yeah, so I think like a lot of things in hospital politics and healthcare politics and policy, it's like the interaction of various different provisions that have created a market situation. So I think and hospital market power in many ways comes from the interaction of network adequacy rules, certificate of need laws, basically a whole different array of barriers to entry. And I think the best way to think about competition is that if you have free entry, and you have an incumbent organization that's making enormous profits on a service line, or even that just has inflated costs on a service line, or it has substantial market power on its service line, it can use its, as a non-profit organization, it can use its market power to drive up prices, and it can gain the market power by consolidating, buying up associated physicians or other hospitals. But so long as newcomers can come into the market, they can undercut. And so it's almost like a necessary condition of market power that there be barriers to entry. Mergers and consolidation aren't necessarily evils. You can have mergers that eliminate excess capacity. You can have consolidation that is a source of efficiency. But the question is, what is the external context? If you have an external context where insurers are very vulnerable to hospital organizations that have a large amount of market power, then you're going to get mergers of the kind that are oriented towards increasing their ability to extract high prices from insurers. If you have low barriers to entry, you're not actually going to see that many mergers that are oriented towards extracting high reimbursements from insurers. The mergers you will see will actually be more oriented towards eliminated excess capacity, which is actually what the mergers of the 80s were more like. So it's not that mergers and consolidation is necessarily bad. It's mergers and consolidation in the context of barriers to entry and the insurance market regulations that we have.
Members, thank you so much for coming, Chris. This is obviously wildly important issues for us that we're facing. We appreciate you joining us and lending us your expertise today. So thank you.
Thanks for inviting me.